Welcome to today's Explainer. We are diving right in, putting on our medical detective hats to investigate a really frightening clinical puzzle. We're looking at the combination of severe, unprovoked fevers and incredibly angry skin rashes. For doctors and parents alike, seeing this is a massive red flag. But what actually happens when the standard medical playbook just completely fails to find the culprit? Well, let's crack the case. So picture this alarming scenario. A child is brought into the clinic with a raging high fever and a severe skin rash. Your immediate instinct naturally is to look for an infection, right? Viruses, bacteria, fungi, the usual suspects. But test after test comes back totally negative. There are no invaders, no infectious disease at all. And yet, the body is completely at war. So the big question we have to ask is, what on earth causes a severe fever and rash when there is absolutely zero infection to fight? The answer actually lies in a category of conditions known as autoinflammatory syndromes. Basically, these are a heterogeneous group of rare disorders marked by recurrent fevers and unprovoked inflammation, completely without an infectious cause. What's happening here is, frankly, a terrifying glitch. The innate immune system, which is your body's first line of defense, just starts mistakenly attacking the body itself. Now, this isn't an autoimmune disease where specific antibodies are attacking specific tissues. No, it's more like the body's general alarm system is just permanently stuck in the on position, flooding the whole system with systemic inflammation. To ground our evidence, we have to look at the patient with hereditary inflammatory disorders. Our understanding really started with early discoveries of conditions like familial Mediterranean fever, or FMF, and Papa syndrome. For a long time, doctors just called these periodic fever syndromes. In FMF, for example, a tiny variant in the MEFV gene, which encodes the protein pyrene, causes the body to overproduce an inflammatory molecule called interleukin-1 beta. This leads to these short, violent episodes of fever, arthritis, and rashes. It proved that a tiny genetic typo could create massive, recurrent systemic fires. And if we want to understand the root of the problem, we have to look deeper into the cells at autoinflammatory disorders of ubiquitination. It's a really complex chain. Think of ubiquitin as a molecular tag that marks proteins for destruction or alters how they function. If there is a glitch in this tagging process, proteins either build up or they signal improperly. Specific genetic failures disrupt this entire chain, causing really severe adult-onset conditions like VEXAS syndrome or proteasome-associated diseases like PROS. The invisible cellular machinery is just fundamentally broken. Let's compare a typical immune response versus an unprovoked autoinflammatory response to really grasp this. Think of a typical immune response like a well-functioning thermostat. The house gets cold, say a virus enters. The heat kicks on, the virus is destroyed, and the heat turns back off. Pretty simple. But an unprovoked autoinflammatory response, that is a broken internal thermostat. The heat turns on full blast when the house is already warm. There's no trigger, no virus, no bacteria, just pure unprovoked inflammatory heat, manifesting as fevers, joint pain, and those severe skin rashes. Okay, let's look at our specific suspects. The first suspect in our medical mystery is NOMID, which stands for neonatal onset multisystem inflammatory disease, though in Europe you'll often hear it called SINCA. This is the absolute most severe form of a group of disorders called CAPS, which are tied directly to mutations in the NLRP3 gene. We're not talking about a mild childhood fever here. This is a severe chronic disease that begins almost immediately at birth. So what are NOMID's visual and clinical clues? Well, they are highly striking. These infants develop a persistent maculopapular hive-like rash right from infancy that sort of fluctuates in intensity. Their blood work shows incredibly elevated inflammatory markers like CRP, ESR, and SAA. Physically, they can present with unique facial features like a scooped saddleback nose or a protruding forehead. And if a doctor takes a biopsy at the rash, they'll find an unusual gathering of immune cells called neutrophils right at the eccrine coils, the sweat glands. On top of all that, these poor children often suffer from conjunctivitis and progressive hearing loss. It's a truly devastating systemic attack. Moving on, suspect number 2 is SAVI, or sting-associated vasculopathy with onset in infancy. This condition is caused by a gain-of-function mutation in the STING1 gene. Now, in normal biology, STING is a sensor that detects misplaced DNA, usually from a virus, and it triggers interferons to fight it off. But in SAVI, this STING sensor is hypersensitive. It's constantly firing, completely flooding the infant's body with interferons and causing catastrophic inflammation in the blood vessels. And check out this number, 76%. In a systematic review of SAVI patients who actually underwent a skin biopsy, a striking 76% exhibited vasculopathy. That means visible inflammation or damage to the blood vessels themselves. This is a massive diagnostic siren for doctors. When that unprovoked rash is biopsied, seeing damage to the vascular walls is a glaring clue pointing straight toward an interferon-driven disease like SAVI. When we're investigating SAVI, we see it isn't just skin deep. Beyond those early onset severe skin lesions, which terribly can literally cause tissue loss on fingers and toes, over half of these patients develop interstitial lung disease, or ILD, severely impacting their ability to breathe. Their labs show elevated IgG and CRP and ESR markers, and tragically, treating SAVI is incredibly difficult. While medications called JAK inhibitors are used to try and target the pathway, many patients show an inadequate therapeutic response to them, leaving doctors fighting a really uphill battle against the inflammation. All right, let's meet suspect 3, mevalonate kinase deficiency, or MKD for short. You might know the milder form of this by its old name, hyper-IgD syndrome, or HIDS. Now, unlike our first two suspects, which are linked to immune sensors, MKD is a metabolic autoinflammatory disease. This means the inflammation is actually a downstream consequence of a fundamental error in how the body processes cellular energy and building blocks. Here's how the mevalonate pathway glitch works. Step 1. The patient inherits mutations, typically in the MVK gene or sometimes in the downstream PMVK gene. Step 2. This mutation causes a defective conversion in the mevalonate pathway, which is a critical cellular assembly line. And step 3. Because the assembly line is broken, we get dysfunctional isoprenoid biosynthesis. That's a fancy way of saying there's a shortage of specific lipid tails needed for certain proteins. Without those tails, the cell's balance is thrown completely off, and it accidentally triggers the pyrin inflammasome. Boom, fever and rash. Because genetic testing takes time, doctors rely on clinical predictors of MKD to spot it early, often using the Eurofever criteria. The disease almost always has an onset age of less than 2 years. During a fever episode, patients suffer from aphthous stomatitis, painful mouth sores, as well as generalized lymph node enlargement, and persistent, severe diarrhea. Interestingly, an absolute absence of chest pain actually points toward MKD rather than other fever syndromes. Hitting these criteria strongly guides the physician to order the right genetic tests. And that brings us to suspect 4, DADA2, which stands for deficiency of adenosine deaminase 2. This is a recessively inherited disease caused by pathogenic variants in the ADA2 gene. DADA2 is honestly kind of a chameleon. It can present in infants, sure, but also in adults. Its symptoms are so incredibly varied that it often mimics other known conditions, which leads to some pretty dangerous misdiagnoses. Awareness of this is absolutely crucial because of this number, 35,000. Based on population genetics, that's the estimated number of DADA2 cases worldwide. In the realm of monogenic rare diseases, 35,000 makes DADA2 surprisingly common. It is out there, hiding in clinics around the world, totally misclassified as other forms of vasculitis or immune deficiency. So what are the DADA2 clues we need to look out for? Well, it's a terrifying mix. The rash is often levodoracemosa, which is a really distinctive purplish lace-like pattern on the skin that indicates inflamed blood vessels. It actually causes a systemic vasculitis that perfectly mimics a disease called polyarteritis nodosa. But the most devastating clue? Early onset ischemic and hemorrhagic strokes. To complicate matters even further, it can also cause bone marrow failure and immunodeficiency, leaving these kids totally vulnerable to infections. But here is why solving this mystery matters so much. A recent international consensus statement noted that, quote, treatment with TNFI significantly lowers the risk for ischemic and hemorrhagic strokes and other vasculitic organ injury, end quote. Once a doctor correctly diagnoses DATA2, they can prescribe these tumor necrosis factor inhibitors. This targeted biological therapy cools off the inflammation and literally saves these patients from devastating strokes. Catching this is a real game changer. So, solving the puzzle. How do we finally put all these pieces together when symptoms overlap so confusingly? The absolute ultimate weapon in our medical detective kit is the power of next-generation sequencing, or NGS. When clinical symptoms are vague, like when a child has fevers and rashes but doesn't perfectly fit the boxes for NOMID, SAVI, MKD, or DATA2, doctors can run an NGS panel. This lets them look at a massive array of immunologically relevant genes all at once, defining overlapping conditions and finding new, rare mutations we literally never knew existed. We've seen today how tiny glitches in our DNA can turn our own immune systems against us, causing explosive fevers and severe rashes. We've gone from calling these vague periodic fevers to pinpointing the exact cellular thermostat that's broken. So I want to leave you with this question. As our genetic lens widens and next-generation sequencing becomes the standard of care, how many more medical mysteries, hiding right in plain sight, are we about to solve? Thank you so much for learning with us today.